Some housekeeping announcements first. First of all, as you heard in the first session, we invite you to talk about this conference on social media, #CareConference, or at IWPR Research with 1R, or @AU_PGAE. And also, we are going to keep substantive questions to the end and only talk about, only clarifying questions during the presentation. So if you have a clarifying question, feel free to raise your hand. Otherwise, we'll just wait till the end, and we hope to have a good discussion at the end. So today's, this workshop, just to make sure you're in the right one, is Challenges of an Aging Population, Retirement Gaps, and Elder Care. And as you could see from the first conference, there's a lot of overlap when it comes to care work. The people can be caregivers, they can be unpaid caregivers, paid caregivers, they can be caregivers of young people, caregivers of older people. This session, just to sort of situate ourselves, is mostly about older caregivers, elder care, and the impact on unpaid caregivers, predominantly family caregivers. And also what was mentioned in the last session was that this is predominantly an issue relating to women, but in some senses less so for this group than for others, because 40% of adult caregivers are actually men, but the impacts tend to be less on men than on women. So this is still very much an issue, a women's issue, but I just wanted to flag that because I think it's also important to note that a lot of different people, a lot of people this is important to a lot of people beyond just the people. And so we have 4 very, very good presentations today. Everybody's going to be restricted to 9 minutes. Or a little bit extra if they need it. The first presentation is by Siavash Radpur, who's an assistant professor at Stockton University, and prior to that was working at the New Schools Schwartz Center for Economics and Policy Research. And he's presenting joint work with Marta Jaimes at IWPR, but who I don't know if she's here. Oh, hi, sorry, didn't see you. Okay, all right, so anyhow, feel free to butt in then. Okay, the second presentation is by David Knapp, who's a research scientist at the University of Southern California, and he's presenting work that he's done with a team, I think predominantly at RAND, right? So work with Peter Hudomiet, Michael Hurd, and Susan Rohweder. And he will be talking about the role of family proximity and the dynamics of care after age 70. And then next we have AU's own professor. And by the way, I'm a proud AU alum, and I see some of my professors here. If you're thinking about going to grad school or even undergrad in economics, highly, highly recommend the program here. I cannot say enough nice things about it. And Sue is one of the professors, although I predated her arrival. But anyhow, she has a very wonderful presentation, Universal Long-Term Care Reform and the Labor Supply of Caregivers. And last but certainly not least, we have Joel Eskovitz, who's the Senior Director for Social Security and Savings at AARP, and he's presenting on policy solutions to enhance caregiver financial security. And I just want to say that AARP has a really great report, and they update it periodically about the economic costs of caregiving on unpaid caregivers. And so if you haven't checked it out, you should check it out, and I think he'll talk about that, but also about some policy solutions. So without further ado, Sia, please start.
Hi. So I'm going to present a summary of joint research between SIPA, me, and IWPR, Marta Susana, right there. And also I have 2 slides about another project jointly with Monique from EPI. So I take pride in presenting work with other people. But I give them credit. So I'm going to talk about retirement security and poverty among older women, and how systemic challenges actually lead to disparities in retirement readiness. So as I said, we have 2 separate reports here. One is old age poverty and women's retirement income gap, joint project with IWPR, and another one, older workers and retirement chart book, joint project with EPI. The first one is primarily using data from Survey of Income Program Participation, 2022, so I'm presenting 2021 data. And the second one is a bit older, but Survey of Consumer Finances and Health and Retirement Study. The key points are that, first of all, the gender gap in retirement preparedness and retirement income is much larger than the gender income gap, significantly larger, and much larger than the wage gap. When we look at hourly wage, the gap is smaller compared to what the result is in the retirement. The obvious outcome is that we will have higher poverty rates among women at older ages. And since the only way to escape from poverty is to continue working, we will see more women locked into physically demanding jobs, even though the population who actually get to work is much smaller because of age discrimination and because physical ability to work at old ages. It's a small population, but many of them, I will show that, are in jobs that are quite taxing. So, before we start, poverty rates and near poverty rates among women, among older women, is significantly higher than men. We have two bars here. The blue one is a share of individuals living in households below the federal poverty level. And the orange one is share living in near poverty, which is 2 times the federal poverty level, because federal poverty level is too low for most regions and for most households. So we look at both and see who is in near poverty. And as you can see, women have higher share in poverty and much higher share in near poverty. Partially because more women are much more likely to be single and widowed at older ages compared to men. Around roughly 20% are widowed or separated or divorced. And they have much higher poverty rates compared to married women because they don't have the pooled resources. But what's the source of this huge disparity in retirement income and the cause of the high poverty rate? So if you start from the top, we know the wage gap is somewhere just under 20%. Hourly wage gap is somewhere under 20% now. There has been some improvement, but not recently. It's more flat recently. But when you look at the annual earnings gap, it's much higher, 27.8, let's say 28%, because of prevalence of part-time work and women not working as many weeks, as many months as men do. One of the most important factors is caregiving responsibilities that prevent them from being able to participate in the labor force and put the same hours in work. That results in lower retirement savings, lower social security earnings, and lower pensions, of course. So when you look at retirement income, when you put all the sources of retirement income together, the gap between men and women is around 32%, so much higher even than the annual earnings gap. To see why that's happening, let's look at the elements. So Social Security plays a major role in equalizing retirement income. It's still, the gap in Social Security earnings is around 25%, still larger than hourly wage gap because of gaps in employment. But it plays a major role in equalizing retirement income. To some extent, less so in recent years, but to some extent because of spousal benefits that lift some women up in retirement earnings. But again, the effect is relatively small. If you look at pension income, traditional defined benefit plans, the gap is much smaller, around 19%. Not necessarily because pensions are great, pensions are amazing. but they usually come with better jobs, with unionized jobs, better job security, better leave policy, and a smaller wage gap. So good jobs, higher bargaining power, worker-friendly policies will definitely shrink the gap significantly. But again, a very small share of workers get to have pensions. That's a choice to have, that seems like a choice to have a career with a pension plan, but very few people can access that. And if you think about the restrictions women face, caregiving responsibilities, many of them may be forced out of more stable jobs, full-time jobs, and union jobs, and have to pick more flexible jobs that don't offer these benefits. So these are conditional on having a pension. So if you have a pension, that's great for you. But not that many get to have this sort of career. So we end up with looking at retirement account balances. So DC plans, different contribution plans, most common these days. And the gap in retirement savings is huge there. And that is one of the main contributors to the gap in retirement income. Why is there a 42% between median retirement saving of women compared to median retirement saving of men who have plans? So these are, again, conditional. So we are not looking at people who don't have anything. This is conditional on having a plan. But women have much smaller savings compared to men. Again, partially, it reflects the wage gap, income gap, but even controlling all of those, we will see that women are ending up with lower account balances despite having comparable access rates and participation rates. Actually, women are more likely to contribute to their retirement accounts if they have access to one. So the take-up rate among women is not lower than men. But the lower income also restricts the ability to save, because you have to take out all the necessary expenses. And then even if you have an actual similar savings rate, what your real disposable income is, it will be smaller after you deduct all the necessities, expenses of cost of necessities. So again, gender lifetime income gap is much larger than annual income gap. Social Security is a huge equalizer. Really need to protect it and expand it. And okay, pensions are great. What's great about pensions is that they come with great jobs. So we need better jobs for women. We need higher bargaining power for all workers, including women. And we should remember, pensions and Social Security both provide lifetime income. So they are annuities. DC plans, retirement savings plans, don't do that. So then the next step is to annuitize that, and it's more expensive for women. So women have higher life expectancy. So compared to men, they need more savings. So what we see that, they have 42% less, that's despite the fact that they actually need more. So the real disparity is even larger because the need is larger for women. So we also looked at the share of single men and single women who have any retirement savings at household level. Because often, we hear that, okay, retirement savings is a household matter. It doesn't make sense to look at men versus women. They are going to pool resources. But when we look at single men and single women, we see that savings for single women are significantly lower compared to single men. So many of them, the share of single women with retirement accounts is larger than single men, but the account balances are much smaller. So many of them have very small accounts, even under $1,000. So the DC plans are not working for women, partially because of the system, how people who get in and out of labor force are penalized by early withdrawals and by not being eligible to participate in the retirement plans, usually like in the first year or two. And the result is, as you can see, high share of women over age of 65 in physically taxing jobs. So especially for Hispanic women who traditionally have had like a lower retirement preparedness because of migration history, because of a type of jobs that they're in, 44% almost are in physically taxing job after age 65. It's a small population, but also because they face a lot of barriers to even be in the labor force. Age discrimination is especially harsh for women. Okay, I can just pass it on. Key takeaways, things that I have repeated already, so I can just pass it.
I think we all have. Is this on? Okay, perfect. Hi, my name's Dave Knapp. I'm from the University of Southern California. This is joint work with Peter Hudemit, Michael Hurd, and Suzanne Rowetter at RAND. This is work funded by the National Institute on Aging, and it is work in progress. So if you have suggestions or input, or you think it's just terrible, you can come up and tell me afterwards, or you can ask questions at the end. And I just want to say thank you to the conference organizers for inviting me. It's been a lot of fun. I really enjoyed the first session. I'm looking forward to seeing the rest of the sessions over the course of the day. So this is specifically about care and the dynamics of care, and what we do and what we don't know about it. So caring is a personal and it's a social issue. So there's a lot of talk about global aging, both in the US, but across the world. The society is getting older, and that comes with it these large demands for care. And care needs, we know, rise with age. But of course, a longer life also means longer periods of life where there are care needs. There is a great demand for care, and that demand is only increasing. So care receipt is, of course, a function of circumstance and needs. And so we actually know very little about what happens from the point of onset. We know a lot about point in time information. So a lot of surveys talk about what are the care needs at a particular point in time, but we don't really envision it as from onset all the way to death and understanding what that entire process looks like. But family caregivers, as we all know, right, and it's been a topic of conversation, they're on the front line of this. They're kind of the first people there out of the gate to support people or to support individuals when their need of care arises. And typically, they're the preferred form of care. They tend to be less expensive than paid care. And so there's a lot of reason to want to support those individuals and understand more about the needs of those when they arise. Importantly, though, there are many individuals that don't have proximate family caregivers, and when care needs arise, as we'll show today, those individuals tend to go without, particularly at lower levels of need. And importantly, and this is part of the challenge, right, in terms of getting people to care about this issue, is that care needs and caregiving are uncertain outcomes, right? We don't always experience them in their lives. For some of them, they're always there once we've had those shocks. And we experience them perhaps for a short term or a long term. But for many people in society, right, they're not something that they immediately recognize. But it's important because when they do occur, they are demanding on our time and they're demanding on our resources. So in terms of the policy landscape in the United States, and I'm going to focus mostly on old age care today, long-term care services are predominantly privately supported, except for in situations where individuals with care needs have limited means. And that's when Medicaid kicks in. Now, it's important to understand that Medicaid is a state-administered program. It must provide institutional care, but home and community-based services are, in fact, optional. Now, most states have 1915C waivers, and they implement their own HCBS program, but those programs vary wildly by state. And as part of a separate initiative through the Gateway to Global Aging Data, I'm leading a team of people collecting historical policy on the evolution of long-term care in the U.S., and there's a lot of interesting, I think, insights that will come down the line from understanding how these systems have evolved and the policy experimentation that we basically have going on at the local level. But other key aspects to the system is that individuals have to apply for Medicaid, and importantly, it requires that they have sufficient care needs to access these services. And I think this gets glossed over a lot in the policy debate, is that individuals actually need to have substantial needs in order to qualify for these services. So typically, most HCBS programs require a nursing facility level of care, which means you need to have at least 2 or 3 ADLs, which is quite a severe level of care needs before these services begin to kick in. And so that means that there could be, for many people who have just, say, one difficulty, a long period of time where they have difficulty, but there's no program available for them to receive care. And so Medicaid HCBS typically requires a nursing facility. I've already said that. So care dynamics are poorly understood. So what I really mean by this is broadly in the population. So I think we all have in mind kind of a notion of a care trajectory when someone has a shock, but we don't really know the prevalence of how many people have very rapid declines to death versus slow, gradual declines over their life cycle, and what that really means for the costs associated with care. And so that's part of what this work is aimed at trying to understand. So care needs are often unanticipated. They reflect circumstances when the need first arises. Care needs and care received, they evolve over time. And that's what I mean by care dynamics. So you might begin having very limited care needs, but over time, depending upon the level of care that you actually receive, that could actually very expeditiously move towards having much greater care need. And this is really a data issue, right? So much of the data that we have is cross-sectional, so we essentially view them at a point in time. So if I see someone who has 2 limitations in their activities of daily living, I don't know how long, in most data, they've been in that circumstance. They could have been in that circumstance for years, and they're going to be a very different scenario than someone who just had those onset, because if you have 2 ADLs or 3 or more ADLs at onset, the time between that and death tends to be relatively short. So we use the Health and Retirement Study, which is a panel study started at the University of Michigan in 1992. It covers individuals 50 and older, interviews them every 2 years, and it follows both members of the couple until they die. Importantly, they have this notion of an exit interview, which is kind of a quaint name for an interview with your proxies after you die to understand the circumstances associated with your death. Key importance for understanding the activity or for understanding care dynamics is that they always ask people about their difficulties with activities of daily living. So you're able to capture individual characteristics at every point at every interview. And so you see people before the needs for care arise all the way up until their death. This enables kind of that observation of the first ADL difficulty and then subsequent care needs. And it provides that kind of rich contextual information about what family is proximate to them before these needs even arise. I won't go through the entire approach because I'm sure I have limited time because I tend to talk a lot and for too long. So we really just, one of our major innovations is kind of restructuring the data to look at it relative to this first ADL onset, and then looking at alternative care outcomes, and then looking at them in a panel environment, so essentially following them until their death. So we can see differences in care outcomes, be it no care, unpaid care, some form of paid care in a home environment, nursing home care, and then ultimately death. And we have a rich set of controls, notably family proximity. So the HRS asks a question about who are the family that live, who is in your family, where do they live, and we can actually see people who are within 10 miles or 20 miles of where that individual is, or if they co-reside. And so here we really kind of break people up into a couple family proximity categories. Do you have a spouse that lives with you? Do you have a spouse and kids nearby? Do you have no spouse, but you have kids nearby? Do you have no spouse and no kids nearby? And so we estimate this model, and we predict care outcomes by sex and family proximity up to 8 years after ADL onset or 4 interviews. So just kind of some of the highlights is focusing on individuals who have, or women, in this case, with 1 ADL at first difficulty, which makes up 48% of the first experiences of difficulty with ADLs. We see that, I think the first thing I would highlight is that almost 50% of women receive no care. But importantly, if you kind of look at this, people who had no spouse or no children nearby at the onset of the first difficulty, the number of people not receiving care is 20 percentage points higher for those individuals. And that's kind of met by a commensurate decrease in informal care. And so you could see here kind of this rich, or this importance of having family proximate to you at the time of initial onset, and the importance it has for your immediate level of care needs. Now, for women with 3 or more ADLs at first onset, which is 37% of the sample, so I want to kind of highlight that you have basically 2 very almost kind of disparate outcomes. You have groups where you have 1 ADL onset, so it's kind of a gradual start, and then you have groups where you have very substantial onset. One thing that struck us about this, beyond the fact that some of those same relationships still exist, but we see that, no care is much lower, is that many people have died actually by essentially what would have been their first interview after this ADL onset. Now, keep in mind, this is 3+ ADLs at onset. This is the target population for the Medicaid program, because these would be the people who are nursing facility. They have a nursing facility level of care. The people that I showed you before, they're not eligible for Medicaid. So if they're eligible for Medicaid, they're not eligible for HCBS services. These individuals are, but their decline is quite rapid. Here you still see the other patterns where you see there's a small number of people who need no care, but the people who are disproportionately likely to have no care are still those individuals with no spouse or no children nearby. So recognizing kind of I feel like I lost a slide here. So you're going to have to bear with me because somehow one of my slides disappeared, which was perhaps one of the more interesting ones, so I'm going to verbally describe it to you because it's the care dynamics. So essentially what happens is that when you look 8 years out, what happens is these differences that we see initially go away. So essentially those people the large gap of people who were receiving no care for those without family nearby, they go away simply because over time people need some level of care, and so they will eventually find it. But what really matters is that these unmet needs, be they in the general population or specifically for these people without family proximate, they're most prevalent at the initial start or onset of the difficulty. And then what's important also is even those individuals with limited difficulty at the beginning, they're very likely to be dead by 8 years out. So kind of recognizing that this decline, even at limited levels of difficulty, is quite rapid, emphasizes the importance of getting people care immediately. And so kind of my key take points, family proximity is critical. Families jump in where they need it, but there's definitely policy space to engage people and provide care in the near term to help kind of offset kind of these rapid declines. And this is an opportunity for policy innovation. And I think there's a number of things we can think about where we could basically help with fill in some of those challenges for caregivers. I think a lot of them were discussed in the earlier policy discussion about providing paid leave or ensuring people's ability to return to work when they have that immediate need for care. But I'll stop there. Thank you.
Thank you. Okay. Is it on? Okay. Hi, everyone. I'm going to talk about the universal long-term care reform in Korea and the labor supply of the caregivers. This is a co-work with 4 other AU former and current colleagues. Okay, first of all, why are we interested in the Korean case scenario? It's because the Korea is experiencing very rapid aging. So by 2000, the portion of the aging population was around 6% only, but by 2020, it was almost 16%, and it is anticipated to increase even faster trends. So to respond to this increasing demand for the elder care, and together with the increasing labor force participation for women who traditionally had this caregiving role in the household, the Korean government has implemented the long-term care insurance in 2008. So by looking at this Korean case scenario, by looking at a relatively short period of time, we can look at this rapid increase in the elder care needs and women's labor force participation, and also the big government intervention. So that's why we're looking at this Korean case scenario. And in our paper, we aim to evaluate this employment impact of this new long-term care system in Korea. And these are the 3 questions that we asked. Does LTCI reform affect family caregivers' labor supply? And what is the marginal impact of this benefit? And whether it has a gender-specific impact? So this is just a general introduction of the Korean LTCI system, which started in 2008. It's a universal system, so every Koreans aged 65 or older, they're all eligible, and it's a big intergenerational transfer program. And the benefit, the most of the benefit can be received in-kind service way. So about 40% of the people receive the institutional care, and 60% of the people receive at-home care. And in a very rare case scenarios, people can receive cash benefits, but majority of the people receive the in-kind services. So the caregivers visit your home to help you to have these house chores or many necessary activities at home. The finance is the 60% of the cost is financed by this mandatory LTCI contribution, and 20% is covered by the tax subsidies, and from 0 to 20% they are covered by the co-payment by the beneficiaries, and depending on your income or household asset status, it can be discounted. It's a 5-level system, so depending on the elderly's health status or dependency status, you could receive very high level of the benefits from level 1 to level 4. Lower level, moderately dependent people receive the lower level of the benefits. So before I move on to the numbers and all the regressions and the equations, let me just show you some backgrounds of this Korean data and with this intervention of the LTCI system in 2008. Although in this graph, we don't have this long pre-trends, you can see starting from 2008, those people, the older child who answered that their elderly parents live with them decreased from 50% to almost to 20%. And those people, of course, who answer that the elder parents do not live with them or with their sibling increase rapidly. And this is a similar response starting from 2008. Those people who answer that family members other than spouse take care of their elderly parents decrease rapidly, and also those people who said they receive the external care arrangement has increased very rapidly starting from 2008. This is another interesting data that shows the difference before and after 2008. These are the main activities among the mid-aged women in Korea, 45 to 60 years old. So starting from 2008, you see the blue, those people who answered that their activity is work increased rapidly. And those people who said their main activity is care, other than childcare, or care and work together has decreased. This is the answers by the women. You see there's the big difference among the men. This is the mid-aged men of in Korea. 90% of the Korean men, they mainly work, and the rest 10% don't do anything. So that's nothing. So here you can see how the traditional caregiving role is like in Korea. So now going back to the empirical analysis, our goal here to estimate this marginal impact of the LTCI benefits on the family caregivers' labor supply. So as the LTCI benefit increases, how much of that impact does it has on the family caregivers' labor supply? But the issue here is that the determinants of the LTCI benefits, they are also the determinants for the labor supply decisions. So for example, if your elder parents are very, very ill, you're likely to receive the higher LTCI benefits, right? So you may decrease that decreases, alleviates the needs for you to lower your labor supply. But at the same time, if your elder parents are very ill, that directly impacts your labor supply decisions. You're more likely to lower your labor supply decisions. So the direct impacts and the indirect effects through this reform is all mixed, and then that's what we all see from this observed labor supply data. So this is the remedy that we chose. We are going to utilize the discontinuities in this LTCI benefit schedules. This Korean LTCI reform has several discontinuities by its design. One is this 5 dependency categories. The more your parents are ill, you receive the higher, more benefits. And the other one is the economic status. Depending on the beneficiary's household economic status, you may receive the discount on these co-payments. So this is the regression design, discontinuity design that we're using. So we're constructing this B, the amount of the LTCI benefits, which has the discontinuities by the design, right? And then that is determined by the X variables, which is the your elderly's health level, and as well as your household income and asset levels. The idea is that we have this X variables that determines the benefit level. We have that directly in this equation inside of the second term, F, so that this direct impact of this determinant is captured by the beta. And only the impact through the LTCI is captured by these discontinuities through this alpha coefficient. So that is the idea. And this is the result. And as you can see, for the labor force participation for women, we have very strong and positive impacts of this LTCI benefits. And of course, the elderly's health score, health status is negatively related to the women's labor force participation. For the men, we have this largely insignificant result. To show you graphically or to interpret what this number means, for the average profile women of our data, receiving no benefit to minimum level of the benefit increased about 10 percentage points of the labor force participation, and receiving the minimum level of the LTCI benefit to the highest level of LTCI benefit increased another 3 percentage point of the labor force participation. And another interesting finding that we have is that the main activity of the women who said their main activity is care also decreased about the same size. So we can see that this increase in the women's labor force participation really is a result of women who decrease their care activities at home. This is just the result to show that we have largely insignificant impact on the weekly log hours, so there's no significant impact found in the intensive margins. Okay. To conclude, LTCI reform in Korea, it has a large and significant impact on women's employment, and these women are more engaged in care activities at home before the reform. And yeah, we have big plans as next steps. Thank you very much.
Thank you. I saw lunch being wheeled out, so I promise to try to keep it interesting. I want to just confess at the front, I'm an ARP. I am not a caregiving expert. I'm a financial security, retirement security expert, as has already been discussed by Sia. The connections between those two things are significant, and I do want to raise up some of the work of my colleagues. We have a whole team of people that work on caregiving, and this Valuing the Invaluable series that they do and update fairly regularly, as Monique mentioned earlier. So 48 million Americans provide unpaid care. It's roughly $600 billion annually in unpaid labor, and that number has gone up since 2019. And we're talking roughly $7,200 a year, or 26% of their income on caregiving activities. These are really very challenging, financial burdens in addition to the time and labor associated with it. 8 in 10 caregivers report having routine out-of-pocket expenses, and then the work-related strains as well, taking leave. And I just putting this out there to tee up some of the challenges that this causes financially for folks in the short and long term. But primarily, I'm wanting to focus today on some policy solutions to help ease the burden for caregivers. And so moving on to some of these policy solutions, first starting in with some legislation that we are supporting to help caregivers that are working today. So the first one is a bipartisan bill looking at lowering costs for caregivers. This allows you to not just use your HSAs, your FSAs, all these retirement accounts, or I'm sorry, savings accounts, not just for your spouse and dependents, but also for parents and in-laws. Again, recognizing that caregiving is a broader category than just taking care of a partner or a child. The Credit for Caring Act as well, again, this would be a tax credit that you would get for expenses incurred between $2,000 and $5,000. You get about a 30% tax credit there, and this would be for services like home health care aides, adult daycare or day services, home modifications. You see the list there. And again, it covers care for non-dependents and those who don't live with the caregivers. Again, recognizing the idea that you don't have to live under the same roof as the person that you're caring for. In addition, caregiving leave, I think we're familiar with the FMLA. You get 12 weeks of leave benefits for your serious health condition. We support improvements to the FMLA, expanding it to smaller businesses, cover all primary caregivers, including, again, expanding that definition. 19 states, DC offers some form of paid leave. This is something that we're working on. AARP has offices all around the country in every state, and we're pushing for additional paid leave across the country. Moving into kind of the heart of what I work on, which is in the short-term and long-term savings space. And so I think when you think about caregiving and the cost that I referred to before, you know, in the United States, there's not a lot of great short-term lending opportunities. You drive by a lot of, you know, payday lending places or you know, other places where you're being charged a lot of money to get money to spend. So, you know, a lot of folks will look to their retirement accounts. Either you stop contributing, you take a hardship withdrawal, which you would be allowed to do, but then obviously that takes away from money that could grow over time, or you could take a loan and pay it back, but again, that impacts how your money grows over time. Or you leave the workforce early and you're drawing down those retirement accounts. And that's for the people that have a retirement account. It is a reminder that there's half of Americans do not have access to a workplace account. And so, you know, all of our research shows you are 7 times more likely to save for retirement if you are offered a plan at work. And so what we are trying to do more so on the state level than on the federal level is offer these work and save programs, which are state-run programs where if you don't have a plan offered by your employer, you can then sign up and get a payroll deduction through your place of work and invest and save for your retirement. In addition, we are also looking at another way to protect your retirement savings by giving you access to short-term funds. And this is rainy day accounts, emergency savings accounts. It's not going to solve the entire problem, right? I mean, you're not going to save the, $10,000 that I referred to on the first slide, but it can go a long way in at least chipping away at some of the money that you may be, you know, taking out of your own savings account. So these are accounts, as noted here, 2 in 5 adults, 30 plus, didn't set any money aside for emergencies. And this is a problem. It's not just low-income Americans. It's across all income groups. And so what we've been pushing for and working with a lot of large businesses and smaller businesses is for the same thing, payroll deduction for auto-enrollment in emergency savings accounts. Right now, there's an opportunity in this recently passed bill, Secure 2.0, that allows for a connected account. We still would like just a standalone account, but the idea is still the same. You have some account to tap before you start, you know, hurting future you, the retired you, by borrowing from your retirement accounts. And so this is an area, again, that we're hopeful that at least gives some financial cushion for caregivers. And then finally, in terms of larger reforms and something that we're, though we have not advocated on a caregiver credit ARP. I do want to kind of walk through how something like that would work and some of the challenges involved. And so just to take a step back, and I realize, not everyone is super well versed in Social Security, but the way it works is your benefits are determined by your top 35 years of earnings. Of course, if you drop out of the workforce for any number of reasons, you've given birth, you're caring for a kid, you're caring for an adult, those years that you're not earning anything, if you don't have 35 years, those years come up as zero. So that really puts a dent in the benefits that you would get, your Social Security benefits. So there are two main approaches I think people have put out there. One would be to reduce that number from 35 down to 30 if you had 5 years of zeros or close to zeros. Another would be to give you the average wage index, to give you about half of that, 32,000, to make up for the years that you missed. Obviously, if you had a high-paying job, this isn't going to replace that, but at least is better than zero. And so those are two of the approaches there. The real challenge, and one of the reasons I think why we have not full-throatedly endorsed something here, is it's I don't say very easy, but it's much easier to have a caregiver credit for a child. You have a birth certificate. You don't have to make a really strong case that a 2-year-old needs, X number of hours of care. It's 24 hours of care every day. I mean, they cannot care for themselves. Whereas for an older adult, to both prove that this adult needs care, how many hours of care you provided, what the nexus between you and that person is, that type of thing, that can be a lot more challenging. And I think, our general feeling is this would make sense to do a caregiver credit, but, it would make sense to do it both for care of children and adults. And that piece of it still needs some work, and there needs to be a more administratable way to do it. So I think I'll give my 2 minutes back. All right,
I
thanks.
used it already.
So now audience questions, and just so you know, we asked the two panelists who described the scope of the needs and the challenges, to think about policies, because they didn't get a chance to talk about that. And for Sue, because she talked about policy that was enacted, was to maybe think about what the politics were, how that was enacted, and whether that could be replicated in other countries, maybe here. And for Joel also to talk about what maybe a little bit more about either the caregiver credit or other things, but the politics that might be challenging or supportive of these policies. But before any of that, if we prefer to get questions from the audience, and there's a lot of expertise in the audience. In fact, I see Heidi there. I don't know if she's got a question, but she's one of the forerunners of all of these, caregiver credit and everything else. So anyhow, does anybody here have a question? Yeah.
Hi, good morning. My name is Keisha. My question is if you can speak on the racial breakdown of the retirement income gap, because I know there's a huge gender wage gap and it's significantly worse for Black and Hispanic women. So I wanted to know if you can speak on that.
Yes. I don't think we managed to get a good breakdown by gender and race at the same time, because the sample size would be too small for getting a good sense of median. We need a larger sample for getting the median. So that's why I didn't present. But yes, obviously, on one hand, we know that the caregiving responsibilities are also much heavier for Hispanic and Black women, despite the fact that they're less likely to have old parents that need caregiving because of the shorter life expectancy. We know that a larger share of them engage in daily caregiving, which keeps them out of the labor force. And we know there is a significant gap in retirement savings and retirement assets in general for Hispanic families that have, if I remember correctly, like much less than even black families because of, again, the type of industries and jobs that they are in. Yeah, unfortunately, I don't have this slide, so I can speak about the numbers. But yes, because of the structure of the labor force that pushes people into specific industries and jobs that don't offer retirement plans, there is a huge gap, especially for Hispanic families.
Heidi? Also, please identify yourselves. I should have said this earlier.
Heidi Hartman, IWPR alumna. I have a question for you, Joel, which is there's still evidence that when women have 401ks, well, women and men have 401ks, that when I last looked at it was, some time ago, women are definitely more likely to take that money out for taking care of their families, college tuition, mortgage payments in the recession, and not to put too fine a point on it, but we noticed that men did buy more leisure goods like boats and things.
Yeah, I think that still stands. I feel, at least they're not in the 10% that do nothing, like in South Korea. So. But yes, I think that.
Another question here from the audience?
Hi, my name is Michael. I'm a first-year AU student, and I was a student of Professor Bach, and I have a question for her. I'm not familiar with when the policy started, but I am familiar with South Korea having mandatory military service requirements across the population. In terms of social preferences and a population's attitude towards enacting something like what they did in 2008, do you see any differences in how that might impact other populations, such as the United States, that have voluntary military service, like in terms of how social preferences in terms of how people view each other and things like that?
Military services and the general consensus on this long-term care service insurance? I'm not sure. But what I can tell you is that I think there was a general consensus on general consensus in the country that they support the idea that we need to enhance the welfare of the elderly. At the same time, the opposite side of this rapid aging in Korea is the low birth rate, and it was the record low, I think, last year, about 0.79 per each woman, and it is expected to be even lower this year. So it's like another problem that is behind of all this aging, the problems associated with this aging society and the lower and lower just participation in the even mandatory military services. But yeah, I'm not sure how it can be related to other countries with this voluntary services. But yes, but yeah, what I can tell you is that it is there was a general consensus, I think, in the country. That's why it could be implemented.
Questions from the audience?
Thank you. I'm Laura Valle Gutierrez. I'm with the Century Foundation. You mentioned in your presentation that single women's savings are significantly lower than single men's. And I was wondering if you could clarify if that's controlling for income, or do you think it is the gender wage gap that is driving that lower savings rate?
it's not controlled because, like, at any point, unless you have a very good panel, you only see the cross section, so you can't really control for lifetime earnings unless you have that from administrative records. So it's just a cross section, seeing the difference. But we know that the life events also have huge impact there. Divorce, separation, many single women, when they experience widowhood, it comes with a huge medical cost prior to that depletes all the assets. So this notion of like, oh, households have pooled resources also hurts those who survive in the end because they feel the obligation that, okay, we have to do everything we can. I mean, I would do the same probably, right? But the consequence is that afterwards, you are left with much lower income and much lower assets.
I'd actually like to add to that. Just there's no evidence that. Sorry, there is no evidence that women are less likely to participate or less likely to save, right? So this is entirely due to circumstances. Yeah, and I know Sia knows that, but and also that to your question earlier about black women, for example, gravitate towards public sector jobs that have defined benefit pensions. They accept lower pay for better benefits. So again, when women have a choice, they try to save. They try to, this is absolutely not a behavioral thing. It has to do with circumstances. So, all right, more audience questions.
Hi, my name is Laura Thorne. I'm with the Direct Care Workforce Strategy Center at the National Council on Aging. And I wanted to ask if you had any opportunity to look into these questions for people who are both professional caregivers, so maybe they're a PCA or a CNA, and also have the personal responsibility of being a family caregiver at the same time.
Yeah, no, unfortunately, we didn't break it down by. Yes. I mean, it's hard to say because, again, one of the main factors that decides your retirement saving is having access to these plans. And for many care workers, depending on where they are, this access can be much lower or much higher. So yeah, unfortunately, it's very difficult to say if it's the nature of the work or if it's the industry that doesn't provide resources.
And I think that there are other sessions that are going to talk more about the working conditions for the paid providers too. So any other questions from the audience? No? So I'm going to throw it to the panelists, again, so either to talk about policies you didn't have a chance to talk about or talk about the politics behind the policies that you did have a chance to talk about. Maybe just take it in turn and okay.
So I want to emphasize the necessity of improving retirement savings for everyone, including women. So when households have financial resources, the need to rely on informal care is lower. So that helps to fill the gaps in care, receiving care. But at the same time, it means that they don't have to rely on their kids. Most of the burden falls on women. So helping people being more financially stable helps their family. So that's why it's important to, even if we are going to think about how much time people are spending out of the labor force for caregiving, one way to address that is to make sure that those who need care can receive it from other places by providing them with long-term care insurance, retirement savings, adequate assets, adequate care. When people don't have these resources, they have to rely on their family. We see part of that as women dropping out of the labor force for caregiving responsibilities, but it also comes with financial burden for children. And especially when it's about spousal care, we can see people going back to work when they don't want to. So caregiving at some point increases labor force participation, but that's involuntary. It's because of the cost. So when you have a spouse that needs care, sometimes you have to go back to work. And that's not the type of work that we want people to have. We want people to have the opportunity to work, but we don't want to force them into the labor force. So it's not just the financial cost of it, it's also sometimes it comes with money. Like if you look at labor force participation, if you look at income for some groups, you will see that, oh, they are caregivers, but at the same time, they are more likely to participate in the labor force. But that's because of the cost. It's not because they decided to do that. It's not a choice. It's not a privilege by any means.
So I think three policy areas or policy ideas that come out of the research that I was presenting. A great deal of emphasis on providing paid caregiver leave to provide essentially that immediate need for care after first onset. I think that's something that has been on the policy menu for quite some time, but I think this research helps kind of emphasize the immediacy of that need for that type of benefit. And compared to providing permanent care, right, it's commensurately less expensive. So it's an easier policy ask, if you will. The other one is that, the recognition that Medicaid requires such a substantial level of need in order to be able to access long-term care services. If we're serious about HCBS, then we need to essentially increase eligibility for it at lower levels of care need. And then I think the other thing, the third one that I didn't really talk about, but it comes out of kind of my international research, thinking about like the long-term care insurance reform in Korea or in Germany or in Japan. What we see as in these countries that have implemented long-term care insurance, as their systems have evolved, they provide kind of this broad-based long-term care insurance system, and then somewhere, a decade or so hence, it becomes very expensive, but they recognize this need for kind of earlier care, and so they introduce benefits aimed at preventative long-term care is often the way that it's framed, and it's often delegated to local communities to help provide those services. But these are things like providing adult day services, different things that are basically HCBS, and just ensuring that those are more available, because when you think about those immediate care needs, if you want individuals to get back to work and remain attached to their labor force and not stop out in order to provide care for their for the people in their lives that need support, then you need to provide those services that can basically enable the ability for them to remain in the labor force while also supporting part-time caregiving needs.
For the politics behind of this Korean long-term care system, I believe that the basis is the general consensus on we need to increase the welfare of the elderly after their post-retirement life times. At the same time, the second purpose of this policy was to alleviate the women who traditionally had this heavy role on the family caregiving. Alleviate their burden was the second the purpose. But then the reason why I think it was possible, this huge intergenerational program, the universal long-term care system, was possible in Korea was, I think, because of the national health insurance system. Everybody in Korea is covered by the national health insurance, and the majority of this cost of the huge long-term care is covered by this mandatory long-term care insurance. Long-term care insurance as a part of the national health insurance system. So their payment was increased for everybody, and it was a rather smooth transition, I think, compared to many other countries who heavily rely on private insurance system.
And I'll just wrap up. I always kind of come back to Social Security because of its universality. As noted before, not everyone has access to savings accounts or retirement savings, and I wish I had the exact stat in front of me, but for folks that drop out of the labor force to do 5 or more years of caregiving, their benefit levels, I believe it's a third of them are below poverty. And so the challenge there, I think, especially for people who rely on Social Security exclusively in their retirement, is to ensure that we have a system that where they can retire with dignity and not be punished for the rest of their lives for caring for loved ones. And it doesn't have to be a caregiver credit. There are other reforms that could be made to bump up those on the lower income scale.
before we thank the panelists, I want to leave you with a little fact that I learned from these panels, which is the ARP estimated that the cost of unpaid care to the caregivers at $600 billion per year, like for 2021. And this is a very conservative estimate because it values the unpaid care at about $17 an hour, so not very much. And the Biden administration had a plan to provide $400 billion for home and community-based services that didn't pass. It wasn't part of the, didn't pass the infrastructure. And this was over 8 years. And it was considered to be a huge amount of money. And it was a huge amount of money, and it would have been wonderful to get it. But just to put a scale on things, the unmet needs are huge, and the burden on families and on caregivers is huge compared to even what was considered to be too ambitious for us to pass. And it was I don't see her anymore, but Mika Mears was here earlier and pointed out that these costs exist whether or not we account for them or not. And so, but mainly, so that's a little factoid to leave you with, but I mainly want to thank these wonderful presentations, and I hope we can all have a system like Korea has, and kudos to the Korean people for passing that, and also to our panelists for very interesting presentations. So thank you.